Hello everyone. Today we are going to be doing the Opioid Analgesics and Antagonists lecture. However, I wanted to start with some websites, specifically just the CDC. I wanted to show you guys some things. You guys have probably heard a lot about the opioid epidemic lately. It has been in the news a lot. Unfortunately, on average, 115 Americans die every day from an opioid overdose. So it's becoming a big issue. Definitely affects, not only people here in the U.S., just citizens, but especially healthcare providers, healthcare professionals, which you guys are going to be shortly joining the ranks as far as your as being PAs. So this is definitely something you need to be mindful of, and you'll notice here too that a lot of the recommendations have become more stringent or more strict with opioids. So historically, and it was interesting when these first came out, there's some different documentaries and stuff. If you guys are interested in, I can share those with you. Just email me if you're interested in, there's some different things on YouTube and some other sources, but there's some documentaries that are really interesting. Where you can see some of the old drug ads, and I believe Purdue is one in particular that. So some of these opioids first came out, brand name like OxyContin, for example, they were advertised as being non-addictive, non-habit forming, and these were things that were prescribed. And so doctors, pharmacists were fulfilling these prescriptions, and they were thought to not be as deadly and dangerous as they are now turning out to be. So that's where it may seem, some of the new language and stuff may seem kind of harsh, but just please appreciate the historical perspective in that, there at one time some of these drugs were considered to be, pretty safe, pretty harmless. You don't have to worry about addiction and stuff that was in some of the ads. So I just did a quick search because I wanted to make sure you guys didn't think I was crazy or whatever, like I'm like a conspiracy person online or whatever. But yeah, so Purdue Pharma was the one that with OxyContin. So this is a quick little video. Just bear with me. Hope you guys can hear the sound okay. But this just illustrated my point.
There's no question that our best,
I'll let him talk.
strongest pain medicines are the opioids, but these are the same drugs that have a reputation for causing addiction and other terrible things. Now, in fact, the rate of addiction amongst pain patients who are treated by doctors is much less than 1%. They don't wear out, they go on working, they do not have serious medical side effects.
See that part about they don't have serious medical side effects, which we'll talk about in our lecture, but there's
So these drugs, which I repeat are our best, strongest pain medications, should be used much more than they are for patients in pain.
So that last part in particular, that they should be used a lot more than they are. You'll notice I have some guidelines and other things coming up, but it's basically, this is where a lot of these newer guidelines and newer recommendations are coming out because of the historical perspective. So anyways, that's just an FYI thing. I never test you guys on the history of these drugs specifically, but that just hopefully gives you guys some context and some perspective as to where we're coming from, with older healthcare practitioners, and how, we were told by the drug companies and some experts like that MD in that commercial, that, you don't have to worry about major side effects, or you don't have to worry about addiction, you don't have to worry about, overdose, etc. And so there were some claims there that we've definitely found out that have not been true. So this is the drug overdose deaths in the United States continue to increase in 2016. This is from the CDC website, cdc.gov. I've recommended you guys use this website for infectious disease, but you can also go here and I would recommend for opioid guidelines. They have a lot of great information on here. You can read through this. Again, this is just going to be FYI. I'm not going to quiz you guys or test you guys on the specifics of how many Americans die and all these different things. That's just, and if you need these links or want these links, having trouble finding them, please just email me and I'll get you these directly. Also want to show you here that there are some commonly used terms just in case you are looking for some definitions. Again, this is from the CDC website, and I try to stick to these definitions and stuff, but you definitely hear a lot of these you'll hear these on rotations, and you'll hear these as a practitioner. So it's good, just make sure you're on the same page. But again, for testing purposes for me, I'm not going to quiz you guys on these definitions, but just, give it a quick read through, maybe definitely stuff you're hearing in your other courses. This other one I like, and this is testable material. So these side effects, this again from that same website, opioid overdose from the cdc.gov, under opioid basics. These side effects we're definitely going to be seeing in my slides here in the presentation you guys are going to be given. But it's just it's a nice kind of overview, and it's definitely something to be mindful of this list. And definitely, as always with all of my exams, you guys are going to be responsible to study the side effects for for testing purposes. But so definitely look through these. And like I said, if you can't, for whatever reason, access the website, ask me. I'll give you the specific link. And then if not, these side effects, adverse effects are in my presentation too. But I'm just showing you that they are listed on the CDC website. If you lose my notes or whatever out when you're a practitioner, this is going to be a great website. One last plug for the CDC, and I promise I'm not sponsored by anything. I wish I was, but they have the guidelines for prescribing opioids for chronic pain, and specifically too, you click on this PDF here and it pops this up, guidelines for prescribing opioids for chronic pain. And this has got some really great clinical reminders. It's a 2-page PDF. It's not too bad. It's pretty short. Something that I think would be worth reading through. I know you guys are pressed for time. It's a stressful time of the semester and everything, but if not now, then maybe when you are on your rotations, and specifically if you're with a pain doctor or someone, a specialist or whatever. But even, I mean, I would even argue that your pain patients, you're going to see them in all settings. You see them inpatient, outpatient. It's something that you'll see in multiple settings. So this may be a good kind of overview before your rotation. And again, I know you guys are super busy too. The second years are always like, thank you for sharing this stuff, but we never have time for any of it. But, I just put it out there. And I remember the same thing as a student. Some of these things I wouldn't look at that professors would tell me about until actually I was a pharmacist and kind of was working my normal job or whatever. So just want to make sure you guys are aware that the CDC is a great resource for any information about the opioids. So that is it for as far as my little plugs intro there. So let's get into the meat and potatoes, as some people say. Opioid analgesics and the opioid antagonists. So the analgesics are pain reducers, that's specifically opioids. And then we also are going to talk about some opioid antagonists, which those block or reverse the action of opioids. So classification here, for testing purposes, please stick to my classification. You may see these classified slightly different. We have the strong, moderate, and weak. But just know that even though they are considered, or rather they're classified as being weak or moderate, all of the opioids now are being considered to be, that you should be more mindful of prescribing them. They've become sort of, they're stricter recommendations. And some of these have been discontinued, which I'll let you know about. Some of them had their schedules changed. So Tramadol went up in schedule. So it's more tightly controlled. But anyways, so, and then these are pretty strong as well. So yeah, don't let this throw you off. There are some, we'll talk about the Dextromethorphan, for example, is over the counter. It's a cough suppressant, antitussive. Loperamide's over the counter. So, relatively speaking, these are, weaker. But again, with opioids, just you need to be thinking about them, and treating them as serious medications. Mechanism of action, just an overview for all opioids. They affect there are endogenous opioids. So here's a list of those. You'll probably be seeing those in pathophys and maybe ICM. But so you have your endogenous opioids. So basically these exogenous opioids, which exogenous means from outside. So these exogenous opioids are these prescription medications. So for example, morphine is an exogenous, or codeine, exogenous opioid. So those basically work on the opioid receptors that are naturally occurring in our bodies. And the reason that we have opioid receptors in our bodies is because we have endogenous or naturally occurring opioids. So kind of simplified, but I think you'll be good if you have that concept there. Here is more on the mechanism of action. Basic take-home point for this slide that these opioids work on the endogenous pain control system, and like I mentioned before, it's because we have naturally occurring endogenous opioids. So go ahead and please read through all of that. And this is just showing a visual representation of the endogenous analgesia system. More mechanism of action here. You will have to be specific, or rather be mindful of the specific subtypes of the opioid receptor. So there's a delta opioid receptor, kappa opioid receptor, and mu opioid receptor. And so what I tell students is, for studying purposes, when I mention those subtype receptors, please make sure you're studying them for the mechanism of action, because there's some medications which we'll notice here, they'll have partial agonists, and they'll work on a couple different receptors. And so, so just please be mindful of that when I note it. So, and we have here a list of, all right, I've had the best I mean, not the best. I've had the worst luck with my stupid cell phone and this module. I don't know what it is. Apologies. I'm sorry. I always silence it. I think I silence it. I'm just, man, amateur hour. Sorry, guys. But anyways, so this is just an overview quick of the receptors, and they are broken down as far as the effects of activation. And you'll notice that they have some different ones depending on which receptor you're hitting. So this may be good for studying purposes when you're looking at adverse effects. So a lot of these effects of activation can actually be adverse effects. So we'll talk about constipation, for example. That's a bit adverse effect if you're concerned with the opioids. The respiratory depression is another one that you have to be concerned with. The euphoria can be a concern just because it can lead to to abuse, and so people will like that euphoria and they will kind of want that high that they have with that. So anyway, so yeah, and analgesia, obviously they'll reduce pain, but yeah, this may be good when you guys are studying your adverse effects, and also with mechanism of action. Like I said too, sometimes we'll talk about how these have maybe working on one or more receptor. So this is a good table here. I would definitely make sure you guys look at this, again, related to adverse effects, and then the reasons they're prescribed. So like I said, analgesia is there and that's why they are just prescribed. But definitely, yeah, put a star here with adverse effects with opioids. Definitely want to make sure you're studying those for your for testing purposes, for my exam and the board exams. It's been, like I said, it's a huge player now. It's in the news a lot. I think we're actually working on developing some special courses and special modules, kind of address the opioid epidemic. And like I mentioned in the beginning, I mean, 112 Americans dying every day on average. It's definitely something that you guys need to be studying, and then, well, I would bet money it will be on your board exams. So yeah, so please look for all of that. Look through all that. Uses here, we've talked about some of these before, like the diarrhea suppression. So the Loperamide can help if you have diarrhea. Cough suppression, there's some antitussive medications. We're going to talk about codeine. We haven't talked about that yet, but dextromethorphan, some of those can help with that. Sedation and relief from anxiety. So for example, the anesthesiologist will use this, and then definitely relief of severe pain. And then please make sure you go back to look at those CDC guidelines as far as, when they are appropriate to prescribe. Adverse effects. So again, like I said, put a star by here. I want to make sure you guys definitely know the adverse effects for opioids. And so yeah, please put a star here and make sure. And this is related to boxed warnings. There's been a lot of new box warnings put on the opioids, more recent history, because of, again, like that Purdue commercial I showed you. It was thought, oh, these don't really have major side effects or major medical side effects or whatever. Well, it turns out, yeah, they do, and there's some pretty big issues with them. Morphine is like aspirin in the sense that it's the prototype. So you remember from when we talked about aspirin, how it's sort of like everything's based off that. So this is the prototypical opioid. And so a lot of times when they, for example, when they talk about them being strong, moderate, or weak opioids, or if they talk about their adverse effects and stuff, or as being less or not as bad, it's always in reference to morphine. So you'll see that throughout this presentation. And so always think of that when you're studying and learning about the opioids, is that these, it's always, morphine's going to be your prototype that you're always going to compare to. So we have the administration here. Notice it's, IV, IM, rectal. And that's mainly because it's not as effective when you're giving it by mouth, but it can be given by mouth. They make a liquid morphine, for example, that I know. Oral extended release products are also used. Primary use here, again, it's going to be reserved for severe pain, and there's some box warnings on that coming up, and then some of the other uses there you can read through. But like I said, box warnings, as always, this presentation is going to be jam-packed with box warnings, and so my apologies that there's a lot of them, but like I said, hopefully the history and like I said, the number of Americans dying every day and stuff kind of explains why there are so many box warnings and why these medications should be taken more seriously. But definitely go ahead and read through these. I don't want to just read. There's a ton of box warnings. You'll notice with the box warnings too that there is a pattern that a lot of these box warnings repeat themselves. However, please read through all of them because there are some unique box warnings for some specific opioid products. So like codeine, for example, I know has some unique box warnings. So I know as a student, it can get kind of laborious and sort of things can start getting blurry, so to speak. Like you see box warning after box warning after box warning. You're like, okay, yeah, I get it. But please make sure you are looking through and reading each one. But like, for example, addiction, abuse, and misuse, you're going to see that on all of them. But yeah, so there will be a pattern you'll notice here. I mentioned the respiratory depression as being a serious adverse effects, but definitely there's a box warning related to it. Neonatal opioid withdrawal syndrome, please read through that. Accidental ingestion, risk of medication errors, and then use with benzodiazepines or other CNS depressants, which this is a newer one. This was part of a safety alert that came back out in 2016, but so please be mindful of that. There's synergy. So morphine and the opioids are very good at causing CNS depression. So definitely you always want to think about drug interactions and the concomitant use or the use in combination with other CNS depressants. And specifically the benzodiazepines. So please be mindful of that. Next up, we have the codeine, oxycodone, and hydrocodone, which you guys maybe have a little bit more experience with. These are in popular culture, for better or for worse, unfortunately, like in music and in movies and stuff. So they are relative to morphine. So again, using morphine like aspirin as being the prototype. So relative to morphine, they're less potent and less likely to cause physical dependence. Having said that, they still are potent, strong medications, and they can still cause physical dependence. So I've had students in the past miss exam questions because they were like, well, it says it's less, there's less physical dependence, and so you don't have to worry about it as much with the codeine, oxycodone, and hydrocodone. No, again, that's just relative to morphine. I thought about taking this out because it caused so much confusion in the past, but I left it in. And again, I feel like that's still a relevant point to make. So it's like with a lot of these other classes of medications we've talked about, there, within the class, you can say, oh, codeine has less physical dependence than morphine, but codeine can still have physical dependence. So hopefully that's clear. If not, always email me if you want more specific examples and stuff. But so yeah, I went ahead and go and left that in. And then this is something that's unique about codeine too. I sort of foreshadowed there a little bit in the past that there is a genetic polymorphism with the cytochrome P450 2D6, where you can have variable responses with codeine. So this is where you hear, well, there'll be certain families or certain people that you'll come across in practice who can't handle codeine. And it's basically because you give them a normal, quote unquote, normal dose. And because of their, this genetic polymorphism, they're not able to metabolize it like people who don't have it. And then there's also, so they're ultra rapid metabolizers. And so definitely please make sure you're studying that and look at that. So basically the metabolism can be different depending on your genetic background is take home point for that. Mechanism of action. So, we've kind of already been on this before, and some apologies again, some of this is repetitive, but I just wanted to be thorough and make sure that everyone's on the same page when it comes to these medications. But basically, take home point, they bind to opioid receptors. And so this is what they do. Codeine also can be used for as an antitussive. So it can be used to cough in select patients. Historically too, this has been overdone. Again, I don't know what kind of music you guys listen to or whatever, but the Propoxyphene with codeines and a lot of popular music, syrup and stuff. It was real popular with DJ Screw, the Screwed Up Click, R.I.P. DJ Screw. And those are musicians out of Houston that would overuse and abuse codeine with promethazine. So yeah, unfortunately, it is something that is an issue both legally and illegally. So anyways, that can be something that, and then definitely pain management. And you notice it's mild to moderately severe. But please note there's this limitation of use. I put a star by that. This is just something to guide you when you are prescribing these medications. And by the way, so some of these medications are C2s or and then some medications are which PAs cannot prescribe, and then some medications are just controlled substances and have lesser. So codeine is one that is not a C2, so this is one that you guys will be able to prescribe. And I believe Dr. Poss will be going through all the controlled substance status with you guys when she goes through the prescription writing. But then if not, or if you have any questions about which ones are C2s or which ones are not, or if you don't even know what a C2 is, what I'm even talking about, go ahead and email me. But yeah, like I said, I believe she's going to be covering that with you guys in when she goes over prescription writing, as far as which prescriptions you guys can prescribe and which ones you guys aren't allowed to prescribe. A quick note on that too. There's a lot of C2s in this presentation. So, for example, morphine's a C2, oxycodone's a C2, hydrocodone's a C2. So those are ones you guys aren't going to be prescribing, but I believe you guys should still be learning them, studying them, and knowing about them because they are ubiquitous. And your patients, you can still have patients that are on them, have been on them, are getting prescriptions from other physicians. So maybe your supervising physician is prescribing them hydrocodone, but then you're managing their other medications. So it's definitely still something. Yes, you're still responsible for the test. I've had some students like, hey, since we can't prescribe these, can we not study them for the test? No, please still study these. These are a big deal. They're serious. Like I said, they're all over the place. So even if you can't prescribe morphine, I want you guys still studying morphine. So anyway, so hopefully that'll help you guys when you're studying. But the limitations of use, please read through that, and you're going to notice that this is a newer, it's a newer little warning or note that the FDA has done with these opioids. So like when I was going through pharmacy school, this wasn't part of the presentation, so to speak, but now this limitations of use, quote unquote, you'll be seeing with all of the opioids. And it's basically just, use it if you absolutely need to, and, start low, go slow. And there were some of those things on, I jumped back over here, but some of these things that are these clinical reminders. So opioids are not first line or routine therapy for chronic pain. Establish and measure goals for pain and function. Discuss benefits and risk and availability of non-opioid therapies with patients. And these clinical reminders are good too. So then they're related to this limitation. So use immediate release opioids when starting, start low and go slow. That's where I got that little cool phrase from. When opioids are needed for acute pain, prescribe no more than needed. Do not prescribe ER or LA opioids for acute pain, and that stands for extended release or long acting. Follow up and reevaluate risk of harm, reduce dose or taper and discontinue if needed. So that's where all these new, like I said, these newer things are coming out. So this is where you see the limitation of use. So just be mindful of that. Boxed warnings. So again, please look through this. Medications, addiction, abuse, misuse, respiratory depression, you're noticing again. Accidental ingestion, you're noticing again. This is one that's going to be unique to it, so if you want to just make sure you put a star on that. The ultra rapid get tongue-tied there for a second. Ultra rapid metabolism of codeine and other risk factors for life-threatening respiratory depression in children. So again, related to that polymorphism of the CYP 450 2D6. So hint, please know that, study that. Potential for test, etc. The neonatal opioid withdrawal syndrome, you've seen that before. This is another one too, interactions with drugs affecting the cytochrome P450 isoenzymes. So you do need to be mindful of drug interactions with codeine. So again, put a star by that. Definitely put double stars. So I'm saying put a star for boxed warnings because, like you've seen from all of my exams, box warnings come up on my exams over and over again, board exams, it's board prep exams, etc. So definitely want you to know those. I'm saying put 2 stars by it because you also need to note how these box warnings differ for these opioids. So I'm just highlighting a couple that are different for codeine. And then you'll notice the drug interaction potential with benzodiazepines or other CNS depressants. So we've talked about that before. The other thing too is alcohol, by the way, is a CNS depressant. So students will forget about that sometimes, and practitioners will sometimes forget about that. So that is something to be mindful of because it is a box warning. So they say other CNS depressants. There's a CNS depressant on every street corner in town, right? Now you can go to HEB and get some CNS depressants in the form of beer and wine, right? So yeah, that is something that is also kind of found everywhere in with your adult patients. Hopefully they're over 21. They may be enjoying a beverage or whatever, but it's definitely something you need to be counseling your patients of with these opioids, that it can be a bad deal. Oxycodone. So this is, again, used for pain. So again, please read through all that. Limitations of use, you'll notice that again, so that'll be repeated, but still there's a little bit more specifics there. Box warnings. So again, something you've seen before: addiction, abuse, misuse, respiratory depression, accidental ingestion, neonatal opioid withdrawal. So those are all similar to morphine, right? Again, have to be mindful of the drug interactions here. So oxycodone is similar to codeine in that respect. CNS depression, again, we've seen that before. Medication errors, we've seen that before. Hydrocodone, again, strong pain medications, the C2, like oxycodone C2, if you want to put that on your notes. Pain management, and then again, limitations of use. Please look through that. Box warnings again, and like I said, this is where I think students kind of like start glazing over, or I would as a student, like we just saw this looks exactly like the other slide. So yeah, we've seen addiction, abuse, misuse, respiratory depression, accidental ingestion, neonatal opioid withdrawal. We've seen all those. Drug interactions, we've seen that again with the oxycodone and codeine. CNS depression with benzos and other CNS depressants. And then this one specifically has an interaction with alcohol. For this specific, the Zohydro ER is a specific extended release product. So that the extended release hydrocodone specifically has an additional box warning. So again, a little bit different. So you can put a double star or whatever by that. But definitely be putting big stars on, or whatever you guys put. I don't know, you put a money symbol, do you put the @ symbol? No, yeah, put whatever symbol you want. But yeah, but then also be mindful of these that are a little bit different. I'm not going to make you guys memorize brand names as per usual, but just know that the Zohydro ER is the specific extended release preparation of hydrocodone. Meperidine. So this one, please read through the uses. You'll note this is mainly used by anesthesiologists. So you guys are probably maybe seen this in your inpatient rotations. True, drawing a blank there. Adverse effects, anxiety and seizures are a common one, and that's part of the reason why they, you'll notice back here, a lot of these are short-term uses. So this meperidine should not be used long-term because of increased risk of anxiety and seizures. And then more specifically, if a patient has a history of seizures, they can be maybe be more prone to seizures, then this medication can be a little more dangerous. Please note too, we haven't talked about naloxone yet. We're going to talk about it later, but please note naloxone does not reverse the neurotoxicity of this medication, so it's not effective, and it can actually make things worse. So I don't know if you want to leave it here in your notes or add it later when we talk about naloxone, but please with meperidine know that it's a little bit different when it comes to opioids because naloxone doesn't have the quote-unquote normal effects, which we'll see later. Stay tuned for that. Methadone. So this is a relative of morphine. This is like its cool, laid-back uncle. No, I don't know. Methadone is just, it's a relative. The uncle thing, that was a joke. I don't know how it's related, but it's just chemically related. I mean, I know how it's related. I meant as far as it's this made-up family I'm talking about. So it's a relative to morphine. However, it has a longer duration of action, and it has a milder withdrawal symptoms. Also, unlike morphine, it is orally effective, so you can make a PO, by mouth preparations. So because of those two things, go ahead and please add here. This is a popular drug for heroin addicts. So this is also can be used for withdrawal. And this is where you may have heard of, I don't know if, methadone clinics. And so methadone clinics will help, opioid addicts get off them. And because of that longer duration and milder withdrawal symptoms. And so because of the milder withdrawal symptoms, basically a person will be put on methadone and then theoretically they'll be tapered off the methadone until they are, opioid free. And again, it's orally effective, so you can take it by mouth. And it always reminds me of the movie Trainspotting, which I don't know if you guys have seen that. That definitely is not a good movie for kids or anyone who's weak of stomach or everything. It's a pretty dark and disturbed movie, but it's about heroin addicts in Scotland, I believe. And they were on, they take methadone. But anyway, so that's just what I think about. But yeah, methadone clinics, it's probably in other movies too. It just always reminds me of that. Mechanism of action, please read through this. It works on the opioid receptors, which probably isn't too big of a surprise during this lecture. However, one thing that is unique is that it also has been shown to have a NMDA receptor antagonism. So that makes it a little bit different. Uses here. So this can be used for pain management. So I have filled it before, specifically when I was in the psych hospital. I remember there was one doctor that liked to prescribe it for pain. And so we would fill it for him because he liked it. No, I mean, and he had his rationale, whatever. So there'll be some physicians you may come across that are using this for pain management. It's typically something I've seen just by specialists. So like the psychiatrist, or maybe there was some pain management docs in Tulsa that I worked at there was it was a pain management clinic that had its own pharmacy. So all we would fill were C2s, and basically all we'd fill is opioids all day, every day. And then every once in a while we'd fill like an Adderall for the doctor's teenage son or something. It was like, why do we have like one bottle of Adderall? It's like, oh, one of the owners, because the physicians own the clinic and the pharmacy. They're like, oh, the owner's son, that's his prescription. I was like, okay. But it was just like, bottles and bottles of oxycodone, hydrocodone, and muscle relaxers and all kinds of stuff. But so that pharmacy, I would fill it quite a bit as well. But definitely put a star here for detoxification, and this is unique for this opioid. So hint again, for testing purposes, please make sure that you're being that you note how it is a pain medication, but then it is also unique in that it does have an FDA approved use for detoxification. So like I mentioned with heroin, heroin. Sorry, I have this like, there's certain words like I thought it was funny to say wrong, and then as a joke, and then I keep saying, now I say things wrong, so it's super unprofessional. But like the other one is sandwich. Like like my mom and I don't know who started, but like we say sandwich, and then now instead of sandwich, like I'm gonna eat a sandwich, I say sandwich, and now I can't say it. My wife's always like, why do you always say it? So, and I'm like, because I thought it was funny, and then, excuse me, and then now joke's on me because now I say sandwich, and people like at Subway or whatever the restaurant, they're like, what do you want? Sandwich? So anyways, heroin is the proper way to say it. It's not heron, because again, that's not funny. Heroin and other morphine-like drugs. So definitely go ahead and read through that. You notice two limitations of use. The injectable product here, so it's a little bit different than some of the other limitations of use, is not approved for outpatient treatment of opioid dependence. And so with the opioid dependent heroin patients, for example, if you're at a methadone clinic or you're working, not necessarily that you're working at a methadone clinic, but you have patients who maybe are using a methadone clinic, it will just be that oral methadone, or it shouldn't be if it's outpatient. It shouldn't be in the injection. Boxed warnings, again, notice all of these here. Addiction, abuse, misuse, which I've had students ask me in the past, like, wait, it's used to help people get off of heroin. Why does it have a box warning for addiction, abuse, and misuse? So it is one of those things, and like in that movie Trainspotting, unfortunately, there are some heroin addicts that will abuse the methadone. So basically, they trade their habit. So they were initially addicted to heroin. Well, then they start abusing the methadone, and they'll stockpile it, they'll sell it. There's an illicit market. There's sold on the streets or whatever. And so yeah, it seems maybe a little paradoxical, but and that's part why I'm spending a little more time on it. But it is one that can be used for detoxification, but then it's also one that can be still addictive. So you still have to worry about the respiratory depression. One thing that's unique here, so put a double star or whatever, how many stars you guys are putting, life-threatening QT prolongation. So arrhythmias, serious arrhythmias, torsades de pointes. We've talked about these before. Definitely something you need to be mindful of, and it's a box warning. So definitely if anyone's prone to arrhythmias, you need to be cautious of that and those vignettes, those questions vignettes. However, you also need to be mindful of drug interactions, because you'll remember there's been other medications that we've talked about that can prolong the QT interval. So definitely if, they're already on a medication that can prolong the QT interval and they're on this medication, box warning, life-threatening QT prolongation. Accidental ingestion is there again. The neonatal opioid withdrawal syndrome is there again. Conditions for distribution and use of methadone products for the treatment of opioid addiction. This is also specific to methadone, so please go ahead and read through that. But it's just basically saying that, not anyone can just use methadone to treat heroin addicts. You need special training, special facilities, etc. And there's specific limitations there. Don't worry about going and digging up these limitations, this 42 CFR Section 8. I'm not going to test you in that amount of detail. Just really these bold parts, I mean, are mainly what I'll be testing you guys. So just know that the methadone does need to be kind of handled properly. You notice the drug interactions are concerned here. Read through those. So you definitely need to be thinking about that. And especially with these patients, because unlike with like codeine, it has drug interactions, but the codeine, they may only be taking like the cough suppressant, for example. Maybe they're only taking it for a few days. So you don't, but the methadone, may be more of an issue because they are taking it chronically, or they're taking it long-term taper. So if they also have, if they have high cholesterol, or if they have type 2 diabetes, or if they have a seizure disorder, etc., you know, you need to be definitely thinking about drug interactions with methadone. Drug interaction also with benzodiazepines and other CNS depressants. You notice we've seen that again. Fentanyl. So fentanyl has a patch, a long-acting patch transdermal. They also have it where it is injectable. You can also have buccal tablets, which basically just means, you know, in the side of your mouth, you can put those, like where, I don't know if anyone dips tobacco, which I don't recommend dipping or chewing tobacco, but the buccal is that, you know, pouch in the bottom of your mouth. And they also make lozenges for the treatment of cancer pain. Again, relative to morphine, fentanyl does produce less nausea, which can be advantageous, again, specifically for your cancer patients, because they a lot of times are on other medications that can cause nausea. So it's always an appropriate strategy to try to reduce that for your cancer patients. Mechanism of action, again, basically take on point, it works on the opioid receptors. Here are some uses here. We'll notice that the injection has different uses than the transdermal device. And so it is important to note that, and just go ahead and read through that. They also have the limitations of use. So this is something that you also need to be mindful of. And then too, just a kind of an interesting story. When I was in the psych hospital, there were patients that would eat these patches. So they would chew on them, to get a high. It basically would help break up the transdermal patch, and then they would, yeah, it was the guy almost died. He didn't, luckily, but I got a call from the pharmacy when I was at the psych hospital in San Antonio, and they asked me, what's our protocol for when a patient eats a fentanyl patch? And I said, I don't know. I've never heard of that before. I didn't, no one's ever told me that. I've never come across it. So then they're freaking out. They called the director of nursing. The director of nursing calls me and asks me again. And I'm like, I just told the nurses that I don't know the protocol. So anyway, so long story short, we had to meet with the CEO of the facility, he was an MD, a really nice guy. And we had to develop a protocol for what we do when a person eats a fentanyl patch. So that was interesting, and definitely something I didn't think people would do. But yeah, and so what happened was this guy just basically, he almost stopped breathing. Respiratory depression, right, is an issue. So they had to rush him to the emergency room, and they luckily were able to save his life. But anyways, that's also a potential kind of thing to think about, that these, even though they are, maybe they're prescribed a lot for kind of elderly cancer patients, they can be abused just like the other opioids. Notice some different uses here: chronic pain, cancer pain. I left all these different injection, transdermal device, transdermal patch, and the lozenges in sublingual tags, etc., just to show you guys that there are a lot of different uses depending on how it's prescribed. I mean, how it's manufactured, and so you don't necessarily have to memorize, that the sublingual tablet is for cancer pain, but definitely I want you guys to know this can be used for cancer pain, chronic pain, postoperative pain, acute pain, and then during surgery for anesthesia. So that's kind of take on point as far as the uses and studying for my exam. You'll notice too, limitations of use is here with fentanyl, with a lot of the other opioids. Box warnings, again, the respiratory depression, like I said, that guy almost died of respiratory depression. Addiction, abuse, and misuse. Again, hopefully that story helps you remember that you can chew on these patches. Accidental exposure, drug interactions. So we have the 3A4 inhibitors, again, that we need to be concerned with. Neonatal opioid withdrawal, seen before. Risk with the use with benzos and CNS suppressants, seen that before. Medication error, seen that before. Exposure to heat for the pack, we haven't seen that before, so go ahead and look at that. And there's also the REMS program. So this is a specific, this is a risk evaluation and mitigation strategy is what the REMS program is. So it's just specific to fentanyl, and because unfortunately it has been a big player in the opioid epidemic, and that it is become a preferred, quote unquote, drug of abuse for patients that are seeking to abuse opioids, I guess, or get high off opioids. I don't know how else to say, but so anyway, so that is something definitely that is unique for the fentanyl. And you have probably heard about fentanyl in the news. I feel like I learned about it in pharmacy school, and I fill prescriptions for all the time. And then now it's like all of a sudden I hear it on the news and have family members and stuff asking me about fentanyl and stuff. I'm like, yeah, what do you, I'm like, why are you guys just asking me about that? It's been around. But I think it's because of this, the street use has increased. And when I say street use, I just mean illicit. I mean, sometimes it's from legitimate prescriptions, and then those people abuse the prescribed medication, or they sell it to somebody or whatever. So basically what I mean is illicit or, unintended use. Tramadol. So this is one, a little bit different mechanism of action here, but basically, again, working on the opioid receptors. And it has some effect on norepinephrine and serotonin. So anyways, those a little bit different mechanisms of action to look at those. Adverse effects, you do need to be mindful with tramadol that it can decrease the seizure threshold. So what that means is there's an increased risk of seizures with tramadol. So that's definitely something I want you guys to be studying. It's used for pain management. So for pain, they have extended release and immediate release. Limitations of use, please look at that. And then off-label can be used for RLS. Box warnings. So again, seen these before. Addiction, abuse, and misuse. So, and this one in particular, when it first came out, this was another one. Those were like, they didn't think it was that bad. It wasn't, but now it has changed. And so, the life-threatening respiratory depression we've seen before, accidental ingestion we've seen before, ultra-rapid metabolism of tramadol and other risk factors for life-threatening respiratory depression in children. So this one's a little bit unique. It's a little bit different. Again, it involves a 2D6 polymorphism. So please read through that and make sure you're studying that with tramadol. The neonatal opioid withdrawal syndrome we've seen before. Drug interactions, P450 system, we've seen that before. And then the drug interaction with benzodiazepines and other CNS depressants we've seen before. Next up, we have loperamide and diphenoxylate. So this is part of the generic medication of Lomotil. So these are both can be used to help treat diarrhea. Like we've talked about before in the GI module, the diphenoxylate is combined with atropine, and this is so it does not abused. And basically what it is that atropine gives some pretty nasty adverse effects, and so hopefully remember too, the diphenoxylate is the one that crosses the blood-brain barrier, so that people can or were abusing it and getting high off of it. Like I said, the atropine hopefully will discourage that. Where loperamide is over the counter and does not require prescription, as it's the generic for Imodium, and this one does not pass the blood-brain barrier, and so it is not a popular drug for abuse. And so, yeah, and these are both antidiarrheal medications. I think I mentioned that, but that's there as well. Dextromethorphan, this one isn't a great pain medication. So in opioid, in the sense that it has minimal analgesic activity, is mainly used as an antitussive. So this is one that you'll find in a lot of over-the-counter products. So Robitussin is one that's popular. This presentation is not brought to you by Robitussin. I wish I had some of that sweet Robitussin money. They were sponsoring me. Robitussin, if you're listening to this, I can sell out. You guys can sponsor me, pay for my, no. But I think that it's unethical, and I think that's against university policies. So if the university is listening, University of Texas, please don't fire me for that. That was just a joke. So I don't want Robitussin to sponsor me. Anyways, I did it, and I was like, wait, I got super paranoid. I was like, wait, I think that's actually in my contract. I can't be like a race car driver and go into lecture and just have a Robitussin jacket on with a Pfizer hat and some OxyContin boots. I don't know, some Lipitor jeans or something. I don't know. Yeah, I can't do that. It's interesting though. But anyways, no, I can't do that. That's unethical, against the law, or against the rules of the university. Please note here, there has been a issue with over-the-counter medication, with these over-the-counter medications. So this is where, I don't know if you've heard that kids these days or teenagers they'll robo-trip, quote unquote. And there's probably other slang too. I'm not hip to all the slang, so last year they were laughing at me no one says that anymore. I'm like, okay, whatever they're saying. But robo-tripping was something they said when I was younger, but it was where people would purposely ingest large amounts of the dextromethorphan to quote unquote get high or trip off of. So it can be something that's abused. However, where people get in trouble with these cough suppressants that are over the counter, they do have Tylenol in it. So we've talked about Tylenol, and this is part of the reason why sometimes people overdose on Tylenol, is that there'll be young people who are trying to get high off the dextromethorphan or have that like drunk feeling that the dextromethorphan gives them. And then they'll drink, a bottle of Robitussin or something. And but then the Tylenol in it is what can be deadly and cause the hepatotoxicity, which you'll remember before. And then specifically too, the FDA recommends that these not be used for infants that are less than 2 years of age. So please note that as well. Propoxyphene, this is just here for historical purposes. You may still hear some patients who said they were on it or they would want it or they want to be prescribed it or something. So just don't worry about this for the exam. Just know that it was pulled from the market in 2010. And this was because of serious cardiotoxicity, QT prolongation, etc. And so that was the reason why. So it's just kind of historical. I don't think you guys will see this on your board exams or anything. And definitely you don't have to worry about studying this one for my exams. Just know that, yeah, some of these things I put in there just because there's patients that are still alive that remember this and they may ask you about it. Or I don't think there'll be any doctors who will be asking you about this, but they're patients. Next up, we have the mixed opioid agonists/antagonists, and this is where the mechanism of action is going to start differing a little bit, and where we will need to pay a little bit more attention as far as what specific subtypes they are affecting. So these are effective analgesics. This list we have here, and they the respiratory depression is still a potential, but it's not as bad as with the pure opioid agonist. So that is interesting. Again, that's relatively speaking. And then the associated with much lower risk of drug dependence, again, relative to morphine. So you may still be concerned with some of these, and like I said, well, I think I've said before, you'd be kind of surprised what people abuse and what people do with drugs and prescription drugs and even just like household products or like Freon from air conditioners. People will huff that, or like they'll inhale paint, spray paint to get high off of, and anything. So anyway, so yeah, lower again relative to morphine, but I'll get off my side note there about what people are doing around the house getting high off of. But first off, we have the Buprenorphine. This is a partial agonist on the mu receptor as far as mechanism of action is concerned. Is the take-home point, but you can go and read through this. Very interesting in that it has analgesic effects, but because it is a partial mu agonist, its analgesic effects plateau at higher doses, and then it acts as an antagonist. So this is where the dose of this medication matters. So the lower doses are going to have analgesic effects to help with pain. The higher doses will actually block the opioid receptors, and so they will not help with pain, right? So anyway, so yeah, you go ahead and read through that. But yeah, interesting about the buprenorphine. But take home point, partial agonist of the mu receptor, and then at lower doses, it's going to have analgesia, higher doses, antagonist. Uses here, because of its, like I said, it's different mechanism of action as far as it being a partial agonist. It can be used for opioid dependence, and it can also be used for pain management. So your lower doses, pain management, higher doses, opioid dependence. So definitely go and read through those. Very interesting drug there. At least for pharmacists, a little interesting, mixed. I don't know you guys might not think it's interesting, but I do. Off-label use, please look at that as well. You notice it can be used for heroin-dependent hospitalized patients, and then may have a use with anesthesiologists. Box warnings. So again, probably no surprise here. A ton of newer box warnings. Accidental exposure, we talked about before. Addiction, abuse, and misuse. Again, I noted people like to get high. So again, relative to morphine, maybe less, but still it's a box warning, still something to be concerned with. And still, I wouldn't be surprised if someone right now is getting high off this. I mean, it's sad. That sounds like a joke. It's sad but true kind of thing. So yeah, definitely box warning there. Respiratory depression, again, maybe not as bad as morphine, but still an issue. So box warning. Neonatal opioid withdrawal syndrome, we've seen that before. Risk associated with insertion and removal. This is specifically for the subdermal implant. Don't stress about that one too much, but you can read through that. Notice that there's the drug interactions with the benzodiazepines and other CNS depressants. You'll also notice I've been repeating myself a lot during this presentation, so hopefully I'm not getting too annoying. But then risk of serious harm or death with IV administration. Butorphanol. I don't know what I was reading there. Butorphanol. Said it properly there. This is a kappa agonist and partial agonist of the mu receptor. So again, pay attention. This is where these mechanisms of actions differ a little bit. So definitely make sure you're studying them properly. So this one does produce analgesia, respiratory depression, and sedation, which is similar to the opioid. So the mechanism is a little bit different as far as it's tickling the kappa receptor. I guess you can think of it's an agonist of the kappa and mu receptors. So because of that, it can be used for pain management. It's also, you may see it in your OB-GYN rotation. It can be used for pain during labor. It's also used by the anesthesiologist, maybe preoperatively and during anesthesia. Box warnings again. You guys seen this. You probably know what I'm going to say by now. We've seen this first one, addiction, abuse, misuse, respiratory depression again, accidental exposure. We've seen neonatal opioid withdrawal syndrome. We've seen drug interactions again, specifically with international preparation. And then the also with international preparation, the benzodiazepine and other CNS depressant interactions. Nalbuphine. So this one is an agonist of kappa and a partial antagonist of the mu opioid receptors. So again, a little bit different here. We haven't seen this mechanism again, so please make sure you're looking at it. This one does produce pretty profound CNS depression, so that's related to its uses. Can be used for pain management, but you'll probably see it more with anesthesiologists being used. I mean, I'm thinking, I don't know. I don't know what you guys are going to see, but this. Interesting too, it can be used off-label for opioid-induced pruritus. So that's a unique use we haven't seen yet. Box warnings, we've seen these before. Respiratory depression, drug interactions with benzodiazepines, and other CNS depressants. So just a couple there, but something we've seen before. Pentazocine, this is the oldest opioid agonist-antagonist. However, it's not as popular as it once was. When it first came out, it was more popular just because it was the only one available. But it does have profound CNS and some psychiatric adverse effects, so they can limit its use of hallucinations specifically and disorientation. So be mindful of that. Mechanism of action, again, a little bit different. It is an agonist of kappa. I'm not going to say tickling kappa. I feel like that was kind of creepy. Sorry about that. It's an agonist of kappa and a partial agonist of the mu opiate receptors. So this will help with pain, analgesia, but then you also need to be concerned with sedation and respiratory CNS depression and respiratory depression. So its uses, again, not as popular as it once was, but you may still be used. Maybe the anesthesiologist you're with or shadowing, maybe still using it, and pain management, but I don't know. And then I put here, and so yeah, and the other thing is too, in the US, there's only the injectable that's left available. They used to make oral product. They do still have if you're ever, shout out to Canada, our friendly neighbors to the north. If you're ever in Canada practicing medicine, you can prescribe an oral tablet of that. So a little bit different there. And then limitations of use. It should, like with all the other opioids, be cautious or conservative when using it. Box warnings, again, probably not that surprising. Addiction, abuse, misuse, respiratory depression, neonatal opioid withdrawal syndrome, drug interaction with benzos, and CNS depression. All right, last up, we have the opioid antagonists. So these are opioid blockers. 3 listed here. Please note, this top one is no longer available in the US, so it's here just for historical purposes. The Naloxone and Naltrexone are still available, so you will be seeing those. First up, we have Naloxone. I included the brand name here. Again, not that you're responsible for studying for it, just I feel like that majority of people, even healthcare providers, physicians, etc., refer to this by the brand name. So this is one of those drugs you hear by brand name a lot. Narcan, 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 Narcan. See right there, you heard it a few, but yeah, I definitely feel like it's one of those that it's beneficial to know the brand name. And maybe it's just my limited experience at the psych hospital, ERs and stuff or whatever, different places I've worked. But I just feel like from my professional experience, I hear Narcan a lot more than Naloxone. So anyways, but just for testing purposes, it will always use Naloxone for my exams. So this is a pure opioid antagonist that competes with and displaces opioids at the opioid receptors. So you can see why it's good for an opiate overdose, because it does a complete or partial reversal of the opioid depression. So this is life-saving medication. You'll notice they make IM, subacute, and intranasal. So just there's that. But yeah, these are used for emergency treatment and can be a life-saving medication. So please read through all that and look at that. But opioid overdose is going to be the big use of why it's being used. And then off-label use, the opioid-induced pruritus. I put a dosing note here. Again, just read through it because I normally don't include it, but I felt like it was important because of just the severity of the topic with the opioid epidemic in the US, and then with the popularity of Narcan and it being used. And again, it can be life-saving. So I would really encourage you guys to study this and look through it. I'm not going to necessarily pull test questions from it, but it's one of those things that, again, you could help save someone's life when you're even on rotations, depending on the situation, depending on, opiate overdose, etc. So just know that they do have an IV, which is preferred, IM, subQ, and intranasal. And that for the initial treatment of the opioid-associated life-threatening emergency, the AHA, which American Heart Association, recommends after CPR the use of intranasal or IM naloxone with a repeat dose as needed. If there is an initial patient response, but then the patient then stops responding, begin CPR and repeat naloxone dose. If there's no initial response, continue CPR and use the AED as appropriate. So again, I'm not going to be testing you over this slide in particular, but I think it is important for you guys to be knowledgeable about this, or at least have seen it once, and then maybe you can restudy this when you're on your rotations. Warnings, precautions. So the concerns related to adverse effect. This is testable, so you can make sure you study this. So this medication, it's used for an opioid overdose. So the acute opioid withdrawal. Definitely go ahead and read through this. It is something you need to be concerned with. So it's why it's used. It's used you go up here. It's used for an opioid overdose. But just know that there are some issues when you do reverse that opioid overdose. So please go ahead and read through this. Next up, we have Naltrexone, which is the generic for Vivitrol. Again, I just included the brand name here just because it's maybe something that you'll hear on rotations, etc. But for testing purposes, just study Naltrexone. Mechanism of action, again, this is another pure opioid antagonist. And so it's similar to the Naloxone, or the Narcan. And then a competitive antagonist at opioid receptor sites. And it has its highest affinity, meaning it kind of at most likes the mu receptors. So its use is a little bit different than the Naloxone in that it can be used for both alcohol dependence and opioid dependence. So make sure you note that when you're studying. Same off-label use as the Narcan. The Narcan and the Naltrexone have the same off-label use. Other warnings, precautions, again, detoxify opioid addiction. So patients should be opioid-free, and this includes Tramadol, for a minimum of 7 to 10 days. And then a Naloxone challenge test may be helpful to confirm patient is opioid-free prior to therapy if there are any suspicion. Since urinary opioid screens may not be sufficient proof, patients transitioning from Buprenorphine or Methadone may be vulnerable to precipitation of withdrawal symptoms for as long as 2 weeks. The use of Naltrexone does not eliminate or diminish withdrawal symptoms. So, basic take-home point, when you're using Naltrexone, the patient needs to be opioid-free for 7 to 10 days. So please make sure you highlight that. And you're studying that for my exam, and then it gives a rationale why. Because it basically just makes the withdrawal so unbearable, etc. So for alcohol dependence and opiate dependence, again, even if you have a negative urine screen, you need to make sure that the patient is truly clear or, opioid free for the 7 to 10 days. Okay, here's a good summary table, which I like you guys to look at. Please read through clinical application, adverse effects, contraindications. And there's going to be a lot to add, because when this book was made, it was before the opioid epidemic was kind of full blown like it is now. So you'll notice there's a lot more strict contraindications, box warnings and stuff, etc. And then also note too, this medication is no longer available in the US. So that is it for me. Thank you guys for your time and attention. I always appreciate it. And as always, feel free to email me question, comments, feedback, or whatever else you guys like to do. So that is it for me today. I will talk to you guys later. Have a good one.